Xiong, and welcome to the Happier Together podcast. This is a bonus episode with extended information from Xiong. This episode will focus on the perspective of social work and the impact that mental health can have on those who utilize services. Please note that there will be descriptions of mental health and substance abuse in this episode. Some listeners may find this disturbing. If you find yourself feeling triggered, the description box will include timestamps for each topic. This is to empower you, our audience, with the knowledge you need to make healthy decisions about how and if you should consume this podcast content. Xiong will be describing their experience working as a social worker and how mental health comes into play. Let's get into the episode. So, Joe, can you describe your experience working in social work and whether people acknowledge or not that they are experiencing mental health issues? And if they aren't, what brings them in?
In the field of social work, quite often we have to consider how societal factors impact the individual. So people may walk in thinking they just need help with housing or substance abuse. But in reality, there's also the additional barrier of them, not being able to obtain what they need as a result of their mental health. So people would sometimes may not believe how intense anxiety can get, but when people can get very anxious, it can stop them from going to a job interview, from going to their doctor's appointments, or socializing and staying connected with family and friends. And then they end up isolating and unable to take care of themselves at some point.
Yeah, let's dig into that a little bit. So, in the field of social work, is the idea that you're addressing mental health issues first, or do you address the societal factors? What determines the prioritization in that?
The reality is a case by case scenario because quite often we come into deciding what should be prioritized, and that's because sometimes mental health challenges are a result of people's substance abuse. For example, using meth can cause people to quite often hallucinate or have delusions. Without the meth, it wouldn't have been a problem at all. People sometimes don't hallucinate or have delusions by meth usage, but those who do, then they tend to often get paranoid and it makes it difficult. And so, in that case, it would be more of a priority to help with addressing their substance use because basically we're thinking if this patient didn't have meth, then they would not be exhibiting hallucinations and delusions. But on the other hand, when people are schizophrenic, things get worse because of their meth use. Then that's where we can kind of figure out, okay, maybe we should focus on psych stabilization, addressing the patient's mental health needs, and of course, stop them or help them with their sobriety. And that way we can help with that individual. And so, again, it's a case by case. We kind of have to look at each person as a whole. So, quite often, we're trained as social workers and therapists to do case conceptualization to really understand the person so we can best meet their needs.
Yeah, that's great. And I think it's important to recognize that there is an individual quality that comes with mental health as well. So, what kind of tools and assessments are done at these visits? How do you measure the mental health severity and help them guide them through the priority of if mental health is a leading concern for them?
Well, we determine the severity of mental illness or substance abuse for that matter. We kind of factor into people's self report, but we can also observe and we can also gather information from collaterals. So the people around the individual who may live with the individual, interact with the individual often. That way, again, we can get a full picture of this individual. Quite often, when people hallucinate and have delusions, they don't have much insight or understanding of what's happening around them because of their hallucinations or delusions. And so, in those cases, for example, it's best for the clinician, should they be competent, to be able to observe and gather information just from observing or talking to the individual. And when there are times where the delusions come in and they interfere with the patient's ability to provide information, then that's where the clinician has to do their best to gather information purely by observation, as well as maybe if there's collateral information, family and friends, coworkers who we can reach out to kind of get a better understanding of the individual. So that's how we'd approach it. People can have hallucinations. There's severity of it and types of hallucinations. Well, first of all, I maybe the lowest intensity is just hearing noises. Maybe it's like the TV when it's just staticky versus hearing voices, and the voices are of people telling the patient that, just putting them down. And then the very intense, we can say, is they get hallucinations to hurt themselves or hurt others, which quite often can influence people to act out on those behaviors. So even then, just providing the three types of examples of hallucinations, you can kind of see the severity and gauge, okay, the person who have command hallucinations to hurt others are probably the most severe and they need a higher, maybe psychiatric inpatient level of care. So that's kind of how we determine the intensity and levels.
So, in your experience, have you seen that younger adults would be more cooperative with engaging in these things? Or has there been differences in generational approaches when discussing mental health?
I'd like to believe that the younger generation, or I'd say younger, but I'm only 27. So our generation and the upcoming generations of millennials and Gen Z, we're more forthright and we're probably more cooperative in terms of seeking mental health treatment. I mean, you can find people's TikTok talking about mental health. For example, there's a couple who are both schizophrenic and they have a TikTok of sharing how they live with one another, how each other have their own hallucinations, and yet they still make it work. So you won't find that in the boomer generation, but there are moments where definitely I've had a lot of other patients that come in who are of the older generation who are willing to seek help, and they may have finally realized that they're dealing with grief and trauma and depression, anxiety, and they may not necessarily have had the vocab or the space or the opportunity to get the help that they need. So it's not to say that one is more close-minded than the other. Honestly, it's tough to say that.
Yeah, I definitely appreciate that honest assessment. And so, do you do a lot more work with crisis prevention? And the reason why I ask that is because I'm curious if people tend to seek assistance more when it's a last resort, or are people actually preventatively seeking services?
It's tough to say because it depends on what population you are hired to work with. For example, my first job was with homeless FSP. So FSP is abbreviated to Full Service Partnership. That's a high intensity work because, first of all, the patients you're working with are homeless. And secondly, they may have been chronically homeless. They've been identified by quite often the Department of Mental Health to be severely challenged individuals, depending on how we talk about crisis management, because to us, crisis management is if someone is actively having a crisis where they're responding to their hallucinations or delusions, or they're actively engaging in self harming behaviors, or they're expressing the will to hurt others, then we can talk about crisis management. And we do our best to not get to that point. So I'd say most of my work has not been that, thankfully, but there are places where that's your daily work environment. The most cases that I've worked with have been more just trying to maintain and hopefully lessen or reduce people's anxiety, depression, hallucinations. before they get to a crisis management situation. I hope it stays like that for most of my cases moving forward as well. It's just generally been providing weekly therapy or biweekly and case management assessments. If crisis management means helping people get housed, get to the doctor's appointment, etc., then I'd say 100% of the work is crisis management, or maybe, I don't know, 90 or 95, and the 5% is patients having a mental breakdown or having, a psychotic episode or in need of a higher level of care.
That's really interesting. And earlier you mentioned that sometimes you have to reach out to extended family or coworkers or just anybody that you can get in touch with to understand the case as a whole. And so when people are seeking social services, is it always based on an individual level or is it ever a family case scenario? And then based on that, how do you assess which approaches would be best?
There's been tons of research based on the types of interventions provided to see what's effective and what's not effective, or what's effective for this population versus another population. For instance, people who are diagnosed with borderline personality disorder on dialectical behavioral therapy, or DBT, is most effective with working with that population or individuals who are diagnosed with borderline personality disorder. So if we think of it like the medical field, you have pediatricians, you have optometrists. There's there's like specializations pretty much when we work with an individual. If it's deemed necessary that it's a couple that needs therapy, we can kind of consider, okay, is couples therapy something that can work? Or if there's domestic violence, that is kind of the issue of what's happening with this couple, then couples therapy may not be most effective, but individual therapy may be helpful, because when domestic violence happens, one partner has more control than the other partner. So it can even be as one partner speaking for the other partner, and then the other partner is shying away, or they don't have much of an opportunity to speak for themselves. Then that becomes a problem. And we have to, as a treatment team, think, okay, maybe couples therapy is not appropriate. Maybe it's more individual therapy for the partner that is being overshadowed in the relationship. There's a lot of like strategic thinking and assessing that comes with like trying to figure out what is most appropriate for people. But there are, of course, times where treatment teams fail, and people come into treatments and they don't get the best or appropriate level of care. But that's, of course, the goal is to avoid that.
Thank you for sharing that. And how do you determine if the strategies that you are using is effective? Like how long do you test out a strategy before determining that maybe that wasn't the right fit or maybe they just need a different resource to help them?
At times, it's a matter of like working with a patient and reflecting with them. So the initial goal is to create a SMART goal with a client, meaning that we try to establish what we're trying to work together on in terms of what's achievable, what's realistic, what's measurable. And so, for example, if a client tells us they want to get $1 million, is it achievable? That's not quite a goal we can work on, but maybe if it's starting off with helping a client get supplemental security income, or SSI, then it's like, okay, that's something we could work on. It's achievable. And we can try to figure out by the end of the treatment goal, which has generally been about a year, you try to work towards this goal with that patient, then we can measure that based on the notes that we document in terms of the service we provide. And hopefully, before the end of the year, we help the client or the patient get SSI. You can apply that to other examples as well. Maybe it's helping a client get to their doctor's appointment. Maybe it's reducing depression from, being every day to maybe like 4 times a week. I mean, of course, we want to get rid of people's depression completely, but is that realistic? Is that achievable? Especially if we have patients who are homeless and they're using substances and they don't have any family members or any support system. Is a goal creating a goal from reducing their depression from every day to just to be completely gone? Is that realistic? It's probably not. So the strategic thinking of helping a client also comes with creating a goal that we both them and a provider can achieve.
And just to level set, is the goal of social work more working towards retention, or is it encouraging for the patient to become more independent? And how do you measure that retention and continuous engagement if that is a requirement?
Yeah, with that, it's more just what the patient wants. Think of it as just customer service. Honestly, if a client comes in and the goal is that they came in wanting to learn about themselves, or we have people who come in and they're required by the court to come and do sessions, then again, that's where we kind of judge. Okay, patient comes in and they say, I'm very anxious and it's hard for me to go to work and I'm dealing with this every day. And the goal may be, okay, are you interested in therapy, or what are you here for? And maybe, the patient may not understand the resources that's available to them, but for someone who maybe have a better idea of what they want, then it's a yes, I'd like therapy, and maybe I'd like to see a psychiatrist to be prescribed medications to help me reduce my anxiety. Then this duration of time that we are working, maybe it's 10 weeks, maybe it's a year, we can continually do therapy. You can see the psychiatrist however often that patient may need. Generally, it's like once a month or once every 3 months, depending on the scheduling and whatever. We continue to check in with the patient, and by the end or near the end of the treatment goal duration of working with the patient, then it's like, okay, how do you feel? Do you still feel like you need our services? First of all, it's important to ask if the treatment's helping. That's the best way you're going to find out with the patient. It's just asking them directly, is this helping? What's not helping? What can be changed to do better? And that conversation happens throughout, you know, the length of time working with the patient. It's not always at the end of the duration. We flexibly change treatment goals as needed because people's needs quite often change in the middle of their treatment. And so, how do we best gauge and cater that depends on how well the clinician is and how the patient is. And if the patient lives a very difficult and ever changing lifestyle, maybe they're couch surfing, for example, then the needs of the patient is ever changing. And so we can move around and work on establishing a goal that can best fit their needs. When the patient decides that they feel better, they may not need therapy anymore, but they'd like to be still on their psychiatric meds, which is quite often what happens. People may feel like they've done enough therapy and they just want to get their psychiatric meds. Then the goal is, okay, maybe we can address that and make that happen. Or maybe it's like, okay, then if that program no longer fulfills the client's needs, or it's been fulfilled, then the goal is to step down the patient or client's level of care, because quite often people come in and they're in a worse state. We do internal transfers. We can also do external transfers between programs and within programs. Those are ways we can kind of help with addressing and gauging what level of needs that the client needs or still need or don't need anymore.
I definitely see the value in social work and why it's such a critical asset in our community. And I was wondering, is there a virtual option that's available, or is it more effective to have these in person meetings to really assess and evaluate the case? An instance that I'm thinking about is, what if the individual is homeless, or if they don't have a mode of transportation, or even a situation like COVID happens again, has there been an evolution of virtual assessments?
Telehealth has expanded since COVID, and I do think that it's important that we make these methods accessible. It will depend on the agency, it will depend on the client and where they're at. There is some aspects of legal and ethical issues that people can run into when providing telehealth. And quite often, the jobs that I see are asking for there to be licensed clinicians to provide telehealth treatment. But more often than not, unlicensed clinicians should be seeing patients, sometimes through telehealth, more of a hybrid approach, some through telehealth and some in person. There's always been a great need for mental health, first of all. Secondly, COVID just made things worse for a lot of people, and it may have made people aware that there's a lot of mental health issues that weren't being addressed in the first place. People are just somehow surprised that people really need mental health support. Telehealth should have been offered in the first place because we think of accessibility because we have to think, okay, how can we address the needs of someone who cannot make it to our clinic, but we have the staff, the training, and the appropriate interventions available for this client? So it can still be difficult because of those barriers. And the root of social work is to help address and limit the impact of these barriers or rid of the barriers entirely so that way clients can get the help that they need.
I'm glad to hear that there's been improvement to make social services much more accessible to the community, especially when you think about the people that will be utilizing the services. It's important that we can cast the net as wide as we can to make sure that the people that need to use the services have multiple ways that they can go about it. I appreciate you sharing so much rich experience with us, and it's important to shine the light not only on social work but mental health and the realities of being engaged with this work for so long. And in the description, I've linked to Joe's social information about how you can reach out to them and just to learn more about what they're up to. Thank you all so much for listening to this podcast, and I hope that we can continue to become happier together.